issues, no issues, no issues.
आपको कुछ नहीं बोलना, आप सब साथ में बैठे रहिए सामने.
Just 1 minute, yeah.
Sir. Bye.
Wait for 1 minute, sir.
Yes.
Good morning, everyone. On behalf of IAP and IAP technical team, I welcome you all. I would like to welcome our today's speaker, Dr. M.R. Zulfi, sir. Welcome you, sir.
Yeah,
Our today's moderator is Dr. Vinod Kaushik, sir. Sir is Vice President, IAP Haryana. Welcome you, sir. Before hand over to moderator, I request all the participants, please like and subscribe IAP India YouTube channel and Facebook page for watching all online webinars. Over to you, Vinod Kaushik, sir, to moderate this session. Thank you.
Hello everyone. Welcome all the delegates. First of all, I show my gratitude towards our host, Dr. Himandri Kapil and Dr. Jaspreet Kaur from IAP India Zoom platform, which has been given to us for the IAP Haryana, this webinar. Thanks a lot. And hereby, I will surely thank Dr. Sanjeev Jha, Dr. Annamalai, Dr. Ruchi Vasta, and Dr. Reddy sir for starting this really integrated for the physiotherapist, this Zoom platform and the YouTube live channel. That is really good starting for everyone. That's a new concept for a physiotherapy profession. Now, I will surely, of course, shows my gratitude and thanks to our IAP Haryana team and IAP Women's Cell, Dr. Uday Yadav, Dr. Kapil Mago, and Dr. Himanshu Shekhar, Dr. Penka, Dr. Rakesh Yadav, Dr. Shad Goel, and from the IAP Women's Cell, Dr. Niti Khurana. Thanks to everyone so that we are able to do this webinar. And now I will just tell a little bit about Dr. M.R. Zulfi, who is our resource person. He's an MPT also, having fellowship in sports medicine and having more than 16 years of experience. He's a director at PhysioActive, the wellness hub, worked with the Artemis Hospital, Sargangaram Hospital, Healers Hospital, a very well-renowned hospital. Today, he is with us for sharing the knowledge with Decoding ACL. And I welcome all the delegates. And I want to tell you, any questions, any queries, you can put on in the questions box. And the best 5 questions will be taken up in the last by Dr. M.R. Zulfi. I will just hand over now the mic to Dr. Zulfi. Please start up. Thank you. Thank you.
Yeah, first of all, I'm very thankful to the IAP team and mainly Dr. Uday Yadav and Dr. Vinod Kaushik, who has given me this opportunity to discuss with you today on the topic of ACL decoding. So basically, before starting the ACL decoding, I just want to tell you how I'm going to outline this. There will be 3 things I'm going to discuss in today's topic, today's meeting. One will be the clinical part of ACL. And the second would be the goals. The goal is of rehabilitation. And third will be the right protocol, which nowadays we are using for dealing or treating with our patients. So that will be all included in your today's presentation. And when I talk about ACL, I would like to start with the history. I would like to start with the history of ACL so you will get the importance of ACL. ACL is a very important ligament which is being recognized since Egyptian times. So there was a scientist, Galen, who for the first time discovered the true nature of ACL. Before that, ACL was considered to be the part of nervous system. So it was first Galen who discovered it is a ligament. Then there was one more scientist from Germany. There were 2 brothers, Weber brothers, who discovered the mechanism of ACL, how it is functioning in gliding and motion of the knee. So they are all contributed for the mechanism of ACL. Then it was one more scientist, that was Bennett. Bennett discovered the test, the special test which we are really using nowadays, that is Leishman's test for ACL. And then time happened and there were discoveries, the evolution of ACL were there. And then finally, it was 1900 when there was a battle, was a scientist so who discovered the first treatment for ACL, that was the ACL repair. But he didn't do much. Then there was Mayo Robson who take it from the battle, and he got a first procedure of ACL repair. So in ACL repair, they find some good results, but it was not that great. Then again, as you know, in scientific world, they research it again and again, and finally they come up with a, the concept of ACL reconstruction. So ACL reconstruction is not a very new concept. It is a concept which is there from last 30 to 40 years. So it was 1980 when we had a golden standard for ACL reconstruction. So you will see there are so many changes in the ACL. Every orthopedician has a different view. So there's same view as per the physiotherapist also. We have a very different view about the ACL, the protocol that we should go this way, we should go that way, and it's a mixed response. And today I'm going to share my experience that how I have dealt with my patients. I have so far seen more than 1000 ACL reconstructions, but I'm telling you every ACL was different for me. So today I just try to decode it so that you can have a better concept, a better knowledge about the ACL. So one is ACL surgery was considered to be a very difficult part because it was, being done in an open surgery where there was a big incision and then they were, doing the reconstruction of it. Then it became so easy due to the arthroscopy, which is a keyhole surgery, which takes a very less time for healing and for the ACL. And even the recovery part is very faster than before. So in today's talk, we are going to discuss it one by one. So let me take you to the ACL first. So ACL is basically one of the important ligament in the knee. There are four ligaments in the knee: ACL, PCL, MCL, and LCL. So ACL is the most significant ligament. So if you see the attachment of the ACL, it is in the deep notch of middle border of left, femoral condyle, and it attaches with the intercondyle eminence, or you can say tibial plateau. Tibial plateau is a very important portion in the knee, which is responsible for weight bearing. So this ACL has two attachments, one femoral, one tibial. So in tibial, it is, you see it has two bundles. One is anterior medial bundle, one is a posterolateral bundle, and they got named because of their attachment in the tibial plateau. So one is, again I'm telling you, AM, and one is PL. AM is anterior medial bundle and PL is posterolateral bundle. So they help in our, prevention of our anterior translation of tibia over the femur. So this is about the anatomy of the ACL. So again, I'm telling you, the strongest ligament is PCL, but still ACL is a very common ligament which is vulnerable for the injury because of its role. So its role is very important. And if I talk about the biomechanics of ACL, being physiotherapists, it is very important for us to know the proper biomechanics of the ACL. So ACL prevents us from the anterior translation of tibia. So anterior translation of tibia. Suppose you are running and you want to stop. So when you stop it, it is ACL which comes into force and it prevents you from the anterior translation. Or you can say in a simple way that it also helps us in the hyperextension of the knee. So it has the same role like hamstring muscle. So hamstring is an active stabilizer, ACL is a passive stabilizer. And it acts as a secondary stabilizer against internal rotation of tibia and valgus angulation at the knee. So it has not a role of, translation only. It has a role of, internal rotation. It is helping us in the tibia rotational component also. So when I talk about these two bundles, AM bundle and PL, so AM bundle is mainly helpful when you are in flexion. So if there is any stress in flexion, so it is AM which is going to get trouble or vulnerable or prone. And when it is injury in the extension, mainly it is PL, because it is PL which becomes tight, taut in extension, and it is AM which becomes taut, tight in flexion. And at the same time, it is opposite. They become lax. The PL becomes lax in extension and AM becomes lax in flexion. So in full extension, it absorbs about 70% of anterior translation load and 85% between 30 to 90 degree of flexion. So this is how it acts. And the tensile strength of ACL is approximately 2200 Newton and is altered with age and repetitive loads. So if you hang ACL on something, it is going to take the load of tensile force of 22 Newton. So this is the strength of ACL. So you can see how strong it is. But because of some sports injury, there are certain angles where you can't help it. You can't prevent it. In US, every, you know, one person among 3,000 athletes have the ACL injuries, and 1.5 lakh to 2.0 lakh injuries are there in every year. So per annum, we see 1.5 to 2 lakhs, injuries of ACL in US, and most of them are due to the sports activities. So my second slide is, how is ACL injured? So usually injured with a twisting injury to the knee or a direct blow to outside of the knee with a contact or a non-contact mechanism. Contact injury can be the best example, hit by an opponent, and non-contact could be sicking, like snow sicking. So when we talk about the contact, if you see a person who is whose foot is fixed on the ground and he gets a hit on the lateral aspect of the knee, there can be sometimes a terrible trade injury. Terrible trade is nothing but it is an unhappy trade where your ACL plus your MCL and your medial meniscus can get injured. So the terrible, you must know about the terrible trade or unhappy trade injury, which is a very important injury in the ACL, and where you are losing two ligaments and one meniscus. And again, if you see, the position of athlete is same as of you can see in the picture in the slide. And then it can be in, skiing like sports where you don't have any contact, or you are running not in a, in a straight way, you are running in a very different way, like in the football or other games or in the hockey. So you have these sort of injuries. And we must understand that ACL is really crucial for the people who are young, like between the age of 30 to 45, or the people who really are dependent on the ACL. And my next slide is signs and symptoms of ACL. So what are the signs and symptoms of ACL? So we have two types of ACL injury. One is acute and one is chronic. So acute is when somebody has injury and he comes to us, so he might be having mark pain and pop is like a sound when he, get this injury, he find or he experience some sort of click or some sort of sound in his knee. Then there can be a significant swelling or pain in the acute stage, and there will be difficulty bearing weight on the affected knee. And sometimes people come with us as though they have locking in the knee during this injury, in the acute injury. Then injury where the knee feels loose, feeling of buckling, giving away, or instability, and pain and swelling. So this is how signs or symptoms are there in the ACL. So this may also be dependent on injuries to other knee structures. Suppose your ACL ligament doesn't mean that your ACL is injured. So ligaments could be medial collateral ligament, that is MCL. It could be posterior cruciate ligament, or it could be posterior lateral corner. And if I talk about meniscus, it could be the medial, lateral, or both. And but mainly it is medial if it is ACL because of the attachment. And then articular cartilage, which is a gliding cartilage on the ends of the bones. So this is how we can see the signs and symptoms of our ACL patients. So diagnosis is very important, because without diagnosis we can't have a proper line of treatment. So in diagnosis, history is something very important. We need to know the history. So whenever we see a patient, it is always better in our assessment we focus more on the history. And physical examination, in physical examination we do lots of things, but the most important test, special test for ACL is Leishman's, or it can be anterior dot test, and then we prefer sometimes pivot shift test. So these are the three tests which are very important. Anterior dot test, you can just do it in 70-degree or 80-degree, and you can just hold the thigh with one hand to stabilize it, and with our one hand you can just do the anterior translation and see how it goes. If translation is more, though, you can just find out there's an ACL injury. And Leishman is, you can just do slightly, you can take it into 20 to 30 degree of knee flexion and then do it. But these two tests are very important in detecting the ACL injuries. And then we have an diagnostic tool like MRI, which is very excellent for evaluating not only the ACL but also the meniscus, articular cartilage, and other knee ligaments. So X-ray is not that important, I think, but yeah, sometimes if you want to see some chip fracture or something, so you can go for it. Otherwise, it is mainly the history, physical examination, and the MR, which can really help you for your diagnosis. And then, what is the acute treatment for an ACL tear? So if someone comes to you with an ACL injury and he doesn't know what is the injury, and he comes to you and you find out it is an ACL tear, so how you have to go? So you can use a price where you can use rest, ice, elevation, compression, protected weight bearing, and brace. So this is very important. You should never neglect, the ice mainly, the compression, and protected weight bearing. Does everyone with a torn ACL need surgery? So this is a question of every patient. If a patient comes to you or he goes to surgeon directly, so his first question is, am I right candidate, or should I really, it's important for me to go for a surgery? No, it is not always important. As I told you, you have to see the candidate, whether he's fit for ACL or not, whether he's really active or not, or whether his age is within that limit or not. Suppose if he's 50 or 55, so I don't think there is any need of ACL reconstruction. But if he's young and his hobbies are like sport, is he's an athlete, yeah, definitely there is no other option. But there are people who can even do it without surgeries also, who really work on their hamstrings and other muscles, and they can do it. So what does not need surgery? Patient is with very advanced arthritis, they should never go for it, because with ACL reconstruction there can be a scar and it can aggravate their arthritic chances. Patients who do not do activities that require any intact ACL, and patients who are not interested in committing to post-operative rehabilitation. So here I am going to emphasize the rehabilitation part is so important for a patient who wants to go for an ACL before pre-operative as well as post-operative, because you have to know whether he's a right candidate for it or not. A candidate who's a lazy, lethargic, and who just want to do it for the sake of ACL and he is going to get the stability, no. If he's not really active and he's not good with the physiotherapy and with the right kind of physiotherapy, he's not going to get a stability for his knee. I have seen many patients who have undergone surgery, but with their lack of right physiotherapy approach, it was a failure. So they didn't get that stability, which I'm going to discuss again in my protocol and my goals. Most patients who perform activities requiring an intact ACL, most active patients, patient is with associated knee injuries, other ligament is meniscal tear, gliding, cartilage injury. So here the patient, suppose, who got an ACL with a meniscal injury, or there's a bucket handle injury. So there is a locking of the knee, and still if we don't advise them that they should go for a surgery, so they are going to deteriorate their further soft tissue structures of the knee. So we should be very clear, crystal clear. If someone has a locking and his knee is very bad, he has a meniscal injury also along, and there is an like if it is not an horn tear like anterior or posterior, if it is a bucket bucket handle tear, so definitely we should send them to a surgeon for the ACL reconstruction. Otherwise, it's going to be a trouble for them. And patient is with associated knee injuries like other ligament is meniscal tear, gliding cartilage injury, and young patient is with an otherwise healthy knee, no injury to meniscus or gliding cartilage. So we should know who's the right candidate for ACL reconstruction and who's the right candidate for, without like for a rehab, like the conservative management. Suppose I have a patient, his name is Sunil Vora. So he got an ACL injury 3 years back, but still he's managing without. He's just 41-year-old and he's still managing without surgery. But his ACL was just ACL rupture. There was no rupture to the associated structure like the meniscus or other ligament. So he's really managing well. So this is how we do it. ACL dependent activities. So now, you know, in some cases, ACL is really important, as I told you. So there are dependent and there are non-dependent. So dependent is cutting sports like basketball, soccer, football, softball, tennis, cheerleading, skiing, snow skiing, etc. And there is high anaerobics, and there is a skateboarding, there is a difficulty hiking. Most laboring job is any activity when the knee buckles after the injury. These are the dependent ACL dependent activities. So we need to keep all these activities into the consideration. And suppose somebody wants to play a football and he comes to me whether I should go for an ACL or not. So I should be very honest and I should tell him, yeah, you are dependent on this. So it is better if you do an ACL. But please, before ACL, get your knee ready. Have some, pre-operative sessions first. After that, you can go for a surgery. It will be easy for you to recoup. And then again, you need to go for a 6 to 8 weeks of a protocol rehab, which is very important. And for sports people, it is important that they should continue it for 3 to 6 months. And non-dependent is walking. In walking, ACL doesn't have much role. As I told you, ACL comes into action when you run and then suddenly stop, or there is any twisting. It is ACL which helps us. Otherwise, ACL doesn't have any role. If you know the home screw mechanism of the knee, when your knees into extension, it has some component of lateral rotation in the knee so that it becomes completely extended, and that extension gives us a stability, more stability. In that stability, ACL and PCL is very significant ligament. So the home screw mechanism is very important. Being physios, we should know if we want to get 100% stability, we need to achieve this mechanism. Otherwise, it is a problem. So for activities, walking, jogging in a straight line, desk jobs, riding a bicycle, ACL doesn't have much role. So we are not dependent on the ACL. And who needs a pre-op brace? So patient is whose knee buckles gives out with every activity. So in ACL also, if you see, we have a different levels of injury. There are three grades in the ACL injury. Grade one is when there is only strain to the ACL or there's a 25% injury to the ACL ligament. And number second is this grade 2, which is approximately 50% injury, or you can say it as a partial tear. And then the third one is your complete injury. This is 100%, that is grade third. So I was, there's like some few years back, I was discussing with someone that why bought up this laser for your clinic. So he was very, confident that this laser is very helpful, like, in treating ACL. So when I just put a question to him. So what type of ACL injury you are treating with this laser? So that physiotherapist was great. He told me the grade three injury. So I told him, though, do you know what is grade injury, grade three? Okay, I know the grade three, and I have treated so many patients with the laser, and they got very good results. There's no pain, nothing, and I treated their grade three injury also. So we had to be very specific with our treatment protocols. Yeah, of course, laser can help our ultrasonic or other, like we have a long diathermy. There are modalities which can help in ACL, but if it is grade one and a grade two, grade three will be never cured. You can't get the attachment design, then your laser can just keep them together and then it can heal them. No, it is impossible. So we should talk very scientific when we deal with our ACL patients. So ACL grade 1 and grade 2, I have seen very good results. I'm using myself class 4 laser. Definitely we get very good outcome of patients. But if it is grade third, you should tell the patient. See, if you want to strengthen of your muscle, definitely you have a active stabilizer, you have a passive stabilizer. Active stabilizer is your hamstring. So the function of ACL and hamstrings is same. So one must know, being physiotherapists, we should know HQ ratio. HQ ratio is the hamstrings quadriceps ratio. Suppose if you see, normally this HQ ratio is 0.5 to zero point 0.8. Suppose if you are a weak person and if I take consider it zero point 0.5, so 5 divided by 10, it will be, if your quadriceps is 2, if your hamstring is 1, your quadriceps is 2. If I take it 8, suppose if your hamstrings is 4, your quadriceps is 5. So quadriceps is always very strong than the hamstring, is being an anti-gravity muscle. But when it comes to an ACL patient who doesn't want to go for a surgery, who has apprehensions and who wants to go with a physiotherapy, so if you find he doesn't have anything serious in the knee and there's just ACL rupture, you can definitely help him. You can just try to reach one. If hamstrings is, if your quadriceps is 5, hamstrings should be also 5. So you try to match this hamstring with the quadriceps. So your aim of strengthening, the focus of strengthening should be more on the hamstrings than the quadriceps. Quadriceps should be also strengthened, but more emphasis on the hamstrings, because hamstring being the active stabilizer can take a role of the passive stabilizer also. So you don't have control on the passive stabilizer that works itself, as you know, but you can definitely help the patient by activating the active stabilizer, which is the hamstring, for the patient to be emphasized on. So what are the risks of not getting your ACL fixed? Every time your knee buckles, you risk injuring other vital structures in your knee, meniscus, ligament, gliding cartilage. What happens if the vital structures are injured? Rapidly accelerated arthritis. Suppose I told you earlier also, if we ignore the ACL sometimes, so definitely patient is going to be in more trouble. There are more chances of arthritis. But if ACL is not into that bad shape, you see the MRI, you do your examination, and definitely patient is not interested and he's not a right candidate. So you can manage it with the rehab also. There are certain football players who play football without ACL. How? Because there is hamstring muscle is at that level and they're using their hamstring muscle to prevent the hyperextension of the knee and the anterior translation. Are there any preoperative requirement for ACL reconstruction? Yes, of course, yes. So in our country, most of the surgeons sometimes they don't take it that seriously. But if you see people who have the exposure outside or the countries like US, UK, any foreign country, Physiotherapist is very important. So when they decide upon a surgery, they always discuss with the physical therapist first whether we should go for it or not, or how much time we require. I don't know here. I was working with Artemis also. There were few orthopedic surgeons very cooperative. They used to talk to me regarding the surgery plan. But there are few who say no, you apna hi kar lo, just do the quadriceps set and all, and that is fine. But I must tell you, ACL is a very technical surgery. It is not like a knee replacement or other surgery. It is highly important to know all of us that ACL is very technical surgery. Whenever we do a protocol, we should know some basic things, which I am going to discuss today. So you should have near normal knee range of motion. Otherwise, surgeon can't get a good outcome. So that can also be done with a good physiotherapist who's going to focus on the knee range of motion exercise. And sometimes patients go to physical therapy pre-operatively to go their motion restore before the surgery. So usually in our country, I think there's a lack of knowledge, or sometimes maybe our our fellow colleagues, they're not interested in that much, or maybe there is some time constraint with our surgeons, so they hardly take our opinion. Otherwise, I must tell you, if you want to have a best income of outcome of an ACL reconstruction, it can be done with the physiotherapist support, with the role of physiotherapist. And 80% role in the ACL reconstruction, the outcome of the ACL, is because of a good physiotherapist. If he has a good protocol, and protocol should be tailored in such a way that you should not only focus on the range of motion and strengthening, you need to focus on the integrity of the ligament as well, which again I'm going to discuss. What should I do before my surgery? Make sure your knee does not buckle. Understand your injury. Ask your surgeon any question that you have. So surgeon should be very, he should be a good listener to the patient. And again, is a problem in our, in our hospitals. Understand what the expected post-operative course would be like, and choose graft. So ACL are not repaired, but rather reconstructed, and thus require other tissue for a graft. So in ACL, we should be emphasizing on a right graft also. So in a graft, we can have a autograft. A autograft is one which is from your own tissue. So it can be a bone, patellar tendon bone, where bone plug from your kneecap, middle one third of your patellar tendon, and bone plug from shin bone can be taken. So here it was no previously we were doing, our surgeons were doing more this patellar tendon graft, but there's only one problem in this: the athletes who have to play, they experience a very big problem in this graft, that is it is very painful, so it takes more time to get healed. Otherwise, the advantage of this graft was that they used to take it along with the bone chip. So for reconstruction and for that, the growth, the healing, it was really helping them. But at the same time, there was some constraint also. And then hamstrings graft, which is again a favorite graft for me also. Like, I saw most of my surgeons with whom I work, they always use this hamstrings graft. And again, I must tell you about hamstrings graft. If they take a double bundle, the tensile force strength is 4400 Newton. When the ACL has actually 2200 Newton tensile strength, but the graft, the hamstrings, but with a double graft, it has a strength of 4400 Newton. So this is very important. And it is less painful than bone patellar tendon bone graft, allows for a very stable knee, and graft of choice for patients with open growth palates. But again, I'm telling you, it is again a choice of a surgeon what type of graft he can take, and every graft is fine. But usually in current scenario, I have seen the surgeons, they prefer more hamstrings graft. And then we have a allograft, like which can be taken from some other source like a cadaver. So it is least painful. Smallest incision can be done in this case. Recommended in patients with significant injuries to other ligaments of the knee. Usually recommended in revision cases. and it is very small risk of disease transmission from the donor. And this is how we see this allograft. So, graft choices, there is no convincing evidence in the orthopedic literature stating that one graft is any better than the other. This is a personal choice and should be discussed with your surgeon. This should be determined prior to the date of surgery. Now, we are going to discuss the very important, part which is really important for us, like being a physiotherapist, that is post-operative physiotherapy rehab. But before starting this, I must tell you about the important goals which I have seen in my experience that we should definitely emphasize on it. So the first goal is reduce pain and swelling. The second most important is you need to restore the movement. You need to increase the range of motion, which all of us know. And then we need to maintain the integrity of the ligament. Then we need to maintain the mobility of the patella. To maintain the mobility of the patella is again very important. And then we need to definitely work on the restoration of extension as early as possible. So these are the major things which we need to discuss today. So I'm going to discuss it one by one. So as you know, for pain and range of like pain, swelling, you can use price and all that is very, and you maybe you can use some electrical stimulation, maybe tense for the patients. But for integrity, it is very important that you should not forget. Your exercise regime should be based on the integrity of the ligament. You need to increase range of motion, but at the same time, you need to see how you are going to increase it. Whether you are going to use an open kinematic chain exercise, you are going to use a closed kinematic chain exercise. So I'm going to emphasize first on the integrity. Then I will take you phase wise also what we are doing exactly. So in the integrity, we when we get a patient, like as in the Artemis, so usually we start the physiotherapy from the first day. So we mainly focus first day or the second day for his pain relief and for his ambulation. So that was our main aim. That was 0 to 1 day aim. But in integrity, we always keep one thing in mind, that we should not start range of motion altogether. We should do range of motion first, 7 days. We should not try to take it more than 70 degrees. So first 1 week, our aim should start with 30 degree and we should take it up to 70 degree. And then every week we should increase the range of motion by adding 10 degrees. Means second week we should be on a range of 80 degree, and third week we should be on a range of 90 degree, and after that up to 6 weeks we should have 120, or we can have 100% range. But during this range, we need to focus more on the closed kinematic chain. Why not open kinematic chain? Because in open kinematic chain, it is the muscle, individual muscle, which has been used, and there can be more stress on the ACL. And surgeon is trying to do his best, getting that stability, getting that tightness in the ACL. And if we start exercise straight away, if we give some stress on the ACL, that is going to get the laxity, and laxity can be going to be the instability. So we need to be very thoughtful that we should not use any open kinematic chain exercise. It should be closed kinematic chain exercise where our foot is fixed on the ground. So then gradually we need to increase it. And close kinematic, a group of muscle is being used. There is less stress on the ligament part, and it is even helpful for patient to do this. And he doesn't have much pain also, and he achieves his weight bearing also by doing this, focus on the close kinematic chain exercise. So that is how this integrity is important. And during this integrity, I must tell you about the role of brace also. So brace is again very important. So brace is important because if you see, we have a quadriceps inhibition after the ACL, because when they do those holes on the ACL, whether it is in-house outside method or outside in method, in both one, your quadriceps is going to be dead for some time. It is going to be into deep inhibition where it is not acting. So whenever a patient comes to you after surgery, if you ask him to do a quadriceps contraction and you compare the normal one, you will feel as if there is no tension in the quadriceps. So he might be using his hip extension on all, but there is no contraction in the ACL. So there you might be starting some sort of stimulation and some sort of more, action on the corticeps, activation. But this is going to determine the brace also. So till this patient is having corticeps inhibition, which is usually 3 to 4 weeks, he should use the brace. And the brace should not be used only for the walking purpose. It should be used for the night also, because night when you sleep you don't know exactly how you behave, how your posture is behaving. So you might get any problem with the ACL. So it is better to use brace for 3 weeks, first 3 weeks during the sleep, and it should be used 4 weeks for the ambulation, or till you feel that he is able to do his quadriceps contraction, because quadriceps contraction is very important to keep your knee in extension. And when he's able to do it, definitely you can progress. And this is going to be very, very important. So these are, very important things one needs to understand when he deals with the patient. And if I now talk about the post-operative rehab, I must tell you we have three phases for the people who are normal, who are not into that much, activities and all. But if he is a sports person, we should opt for a phase 4 also. So what is phase 1? That is 0 to 1 day, where we need to start physical therapy for gait training and pain control. And we have 1 to 7 days, which where we inspect wound daily. We do cryocuff and frequent, price. And it is better if you have a cryocuff. This is really important in ACL because patients are usually in too much pain, and every patient behaves differently. Then we need to use immobilizer in full extension for sleeping and weight bearing, as I told you, 3 to 4 weeks, and weight bearing as tolerated with crunches. So weight bearing can be as much as you can, but there are surgeons who feel that we should not give it up to 6 weeks or up to 3 weeks. But I think for ACL, it is very important to resume the full weight bearing as early as possible, provided they can use some crunch if they have a pain, and the brace should be there, and they can use a walker also, which has a wide, you know, base of support. So they should definitely use, these aids if they have a pain, or they I have seen patients who can do without this also. If they don't have any pain, they just resume day first only full weight bearing with the help of brace only. But pain is there, so definitely you should not put them on too much stress. No, this is a general guideline. No, you go as per individual patient. And weight bearing as tolerated, as I told you, and patellofemoral mobilization as tolerated. So this patellofemobilization, why it is important, patellofemoral mobilization? Because most of patients, when they get ranges, everything, they always have the anterior knee pain because of the lack of mobility of the patella. So that is how it is very important that we should mobilize it. We can just do it, very gentle, without, affecting his suture or maybe the pain. We need to do it without pain. Generally, we can start it, and once it's comfortable, then we can just increase the gliding. We can do it lateral medial, we can do it superior inferior. We can just hold it for 10 seconds one side, then 10 seconds another side. But we should at least, consume our 5 minutes of rehab for the patellar mobility. And then wall slide is for the flexion. It can be, up to 120 as tolerated, as I told you. If you want to go for an accelerated, rehab, where you want to just do it fast, you can definitely do it, achieve it even faster if the athlete is very strong and he's responding well, his quadriceps is activating soon. So you can have range of motion fast also, but ideally it should be up to 90 to 100 degree up to 4 weeks, and by 6 weeks your aim should be to achieve 100% or maybe 120 degree. And full terminal knee extension as early as possible. So we should, when we are trying to achieve the bending, we should not neglect the extension. Again, 5 minutes is with the pattern mobility we should give for the knee extension. We should achieve the knee extension so that we don't have any problem tomorrow in the home secure mechanism, which is very important for us. And then it will come to 7 to 14 days. So as I told you, we should always prefer close kinematic chain exercises. So we should do close kinematic chain strengthening. You must be doing in a different way. So in physioactive, we do it with every patient, and we started after 7 to 14 days. We focus more on it, and definitely the results are so good. And the stability wise, it is really great. I have seen so many patients, and the revision and the injury chances are very less, because if your rehab is really focused on these basic things, it will be really good for your patient's result outcome. And stationary bike for range of motion strengthening you can use. Pool exercise if wound heal. So usually up to 2 weeks I don't suggest the for Indian patients, but the patient is for foreigners, their healing is much better than us, so they can be taken. Or if we have any patient whose healing is really good, he doesn't have any wound, so you can take him to the pool also, where he can do exercises. And start incisional mobilization as soon as possible. So you please focus on those incisions. So there are still certain surgeons who prefer to do it through open surgery only, but 99% surgeons they do it nowadays with the arthroscopic approach. So there are 2 3 like you say incisions where you need to mobilize those. So we need to definitely work on that. And price as needed. Proprioceptive balance board activities should be started you know within these 7 to 14 days of exercise, because ligament has it is nerve supply also. As you know, the tibial nerve, it has a blood supply, that is a genicular artery or geniculate artery which is supplying it. So it has a proprioception also, that is a joint sensation. So joint sensation has to be restored, because ACL is highly technical. You have to perform so many things. You've been an athlete, football player. Your proprioception is something which we really need to work on. And we have different set of exercise. Maybe in my next webinar we are going to discuss on that, what are the exercises and how we can do it. So I can share some videos with you how we do it with our patients at physioactive, and how I was doing it with the patients at Artemis Hospital. So really very interesting. So then this is the phase one. Then I will come to the phase two. Phase two is basically 2 weeks to 6 weeks. So what we need to do is progress flexion to full as tolerated. We need to continue weight bearing to full as tolerated. We need to progress close kinematic chain strengthening, and we need to prevent excessive inflammation edema with price post-operative exercise. So it is very simple. So you need to just focus on progressive strengthening in 2 to 6 weeks, and at the same time the range of motion as I told you. And we have a we have a post-operative physiotherapy rehab, which is now the phase third, which is going to be 6 to 12 weeks. So usually, I have seen my patients, they prefer up to 3 phases only. Hardly there are, I have seen patients who are returning for the phase four. So in phase third, usually we consider it from 6 weeks to the 12 weeks, where we progress to jumping rope, because that time, if you see, the healing time of ACL is 6 weeks. So you can't do too much, the jumping activities, the drills and all, you can't do up to 6 weeks. There are people who do it, but sometimes I think it could be detrimental or harmful for the patient's recovery. So better you should follow the guidelines also in terms of those jumping and all. And you should discuss with the surgeon also that how he's feeling as far as his surgery is concerned. So progress to jumping rope, sliding board, lateral shuffles you can do. In physioactive we have a very fine machine, Ultra-G treadmill, so that is really helping us. So that is how we start these jumping, sliding, everything. too early because of the help of Alter G, where we control the body weight up to 80%, and then gradually we increase the weight bearing on the patients. Then pool running as tolerated, then light jogging permitted, then continue close kinematic chain strengthening. Close kinematic chain strengthening exercise is very important, and being a good physiotherapist, you should keep in mind that you should focus more on after 6 weeks on hamstring strengthening, because hamstring is going to really support the ACL, and this ACL is a reconstruction ACL. So if you want to keep it for long and you want your patient should not return to you so soon, you must focus on his hamstring, progressive hamstring strengthening. And then patients who are into like football or into some sports where they really need a very good knee or strong knee, they should go for 12 to 24 weeks, that is 4 phase. This is increased close kinematic chain exercise. Agility, we can start here. We can start the functional activities as tolerated, running, jumping, cutting, as needed depending upon goal, and functional brace optional for sports or work. So if he's like no, he wants to go for a sports like, and he just wanted to see how he's doing, and also it is advisable that he should go with a functional brace also. That should be an option. So that is how the ACL rehabilitation work. So I am sure with this talk today, you might have certain questions again, which I'm going to answer you, but I think you might have got the clarity that how this ACL works and how this rehabilitation works. And it is utmost important we should know in ACL what we need to do first, where we need to emphasize, and 5 important things. Again, pain relief and swelling integrity, patellar mobility, cortisol inhibition has to sort it out, and we need to focus more on close kinematic chain exercise. No open kinematic chain exercise, which is going to be harmful for your ACL reconstruction. So thank you. This was the entire discussion on the ACL decoding today. And now I would like to have questions from you if you have any questions. So
Thank,
yeah, so Dr. Kosha, so I think I have taken more
thank,
than 45 minutes.
sir. Not a problem. Thanks a lot, Dr. Emma Julfi, for this wonderful session. And here the few questions are there.
Yeah,
And
please.
the one is from our delegate Kapil Kapoor. He is asking, riding a bicycle is not ACL dependent. Why and how?
What is not ACL dependent? Can you repeat it
Riding
again?
a bicycle. Riding a
Bicycle.
bicycle. Yeah.
Yeah, see, I'm telling you, as I told you, the role of ACL is the functions of ACL you need to better understand. ACL is preventing the anterior translation. One. And second, it helps in internal rotation also of the knee. So in cycling, we don't have any sort of translation. Or if we doing cycling is a non-weight bearing exercise where your muscles are acting more than your the passive stabilizers. It is active form. It is a non-weight bearing where quadriceps is working more, where hamstrings is working, but mainly it is the load on the quadriceps. So that is how cycling is not a dependent on the ACL.
One more query from Sadhana Kamlesh. What means buckle knee?
What
Means buckle knee.
buckle knee very is a very interesting question. Buckle knee is giving away. Suppose when you have an ACL injury, there are people they start getting giving away feelings. Suppose they're walking and they can't control their knee, they buckle. So there they have chances of getting more injury to the other ligaments, other structures. So it is because of the proprioception. The moment they get the ACL tear with the ligament, the proprioception is going to get hampered. So when there is no joint sensation, the buckling is more. So this buckling can be prevented from the one, either you teach such patients good quadriceps strengthening exercises, or it is better that patient should be given a brace. So when he is walking, he is not in a position to use his joint sensation or a quadriceps. It should be the brace which is going to help him for the buckling. That is how buckling means for us.
Thank you, sir. One more query. What kind of mobilization techniques we should use after the incision?
See, it is a only no joint mobilization, please. For ACL, no joint mobilization. Only patellar mobilization will be a joint mobilization which can be given, but with the TBO knee joint, no mobilization at all, because we are not going to loosen the ACL. It should not get lax, but there is a soft tissue mobilization which can be given to the incisional areas, because if incisional areas are getting some sort of contracture, because after some time, if you know, after 6 to 8 weeks the tissues get as supple, and if you're not doing initial incisional mobilization, you're not going to get good results in terms of getting 100% knee extension. And as I told you, knee extension is very important, and these minor basic things have really importance in ACL rehabilitation. We need to definitely work on these incisional mobilization so that we are getting a fine extension of the knee and we are not getting any contraction, because most of the patients who complain of pain after 3 months, 6 months, year also after this ACL reconstruction are those who have a lack of extension. So for lack of extension, we need to definitely focus on all these basic things where lateral mobilization and soft tissue mobilization is very important. Soft tissue mobilization is that you can use a kneading or using your thumb, doing some effleurage, some transverse frictions you can do as as patient is tolerance. It should not be too painful for the patient, and you should just see the face of the patient, and then you should use some lotion or maybe some oil, and you should keep on mobilizing those incisional areas.
Thank you, sir. One more query. The last one will be there. What exercises we can do in a pool?
Yeah. So in a pool, it is going to act like, there's an Archimedes principle, the buoyancy, where you are feeling less load on the joint and more load on the muscle. So mainly, again, as I told you, no open exercises. It will be a closed kinematic. You can do squat, you can do lunges, and you can go one leg standing, and you can do, squat in different degrees. So there are lots of exercise which you can do in pool, provided your foot is fixed on the ground. That is how you can use this pool. And as this, the buoyancy effect and the Archimedes principle, it will be really a very good favor for you, that patient is not going to complain any pain also, and you are going to achieve the range of motion very soon, which you have to achieve 100% up to 6 weeks. But if you are using pool, like I'm using nowadays ultra G treadmill, which acts the same way, so I'm achieving the full flexion in 4 weeks only. So that is how you can use the pool for getting your full range of motion. But please don't do any resisted exercise for a patient who's undergone ACL up to 9 months. That even mainly on the terminal 30 degree of knee flexion. Suppose somebody is on a quadriceps table and he wants to perform a flexion exercise. He can, after 3 months, he can go for an open kinematic chain exercise also with the weights and all. But don't go beyond the the terminal range. That is 0 to 30 degree should be without the weight, because if he's using some 5 kgs weight or 10 kgs weight in a terminal range also, that is going to again impact on your ACL, and your ACL may lose its tension. It is going to be lax, and the patient may suffer from instability again. So please try to understand, any exercise you want to do, mainly closed kinematic chain, but after 3 months you have a choice. You can start with some open kinematic, but no resisted exercise in last few degrees of extension. That is last 30 degrees to 0 degree extension. You should never use any strengthening, any weight resisted exercise to your patient.
Thanks a lot for this wonderful session, sir. And the query is coming that how you can get these the recorded video. For all the delegates, you have to subscribe our IAP India YouTube channel. From there, you can get the videos, the recorded videos of all these webinars. Now, I will invite Dr. Uday Yadav, our IAP Haryana President, to vote of thanks. Please, for the vote of thanks, Dr. Uday Yadav, I welcome you.
Thank you, sir. Thank you, Vinod, sir. On behalf of IAP Haryana team, I would like to thank Dr. M.R. Zulfi, Director of Physioactive. Dr. Zulfi is a good physiotherapist with excellent skill, but also an entrepreneur who always believes in new horizon and scopes of physio field. I would like to thank IAP Central team, IAP Technical team, and Dr. Vinod Kaushik sir as moderator. I would like to thank Dr. Monica Chaudhary, organizing chairperson of the webinar, Dr. Mehnawaz for organizing secretary, Dr. Pooja, organizing coordinator, and all the participants who joined the webinar. Thanks everyone, and please like and subscribe our IAP YouTube channel. Thank you.
On behalf of IAP technical team, thank you so much, Dr. Zulfi sir, and all the participants for attending this webinar. And I would also like to thank our IAP President, Dr. Sanjeev Jha sir, and IAP Women Cell National Head, Dr. Ruchi Vashne ma'am, for providing a platform for sharing our knowledge. And I request to all participants, please subscribe our YouTube channel, and you can also follow our Facebook page. Thank you so much, sir. Thank you.
Great, great.
Thank
Thank
you.
you.
Thank you.